Hello everyone. Welcome to Eyezone Education's webinar series. Thank you for joining us. Today's topic is Smart Lens Fitting with Smart Design for KC Management, to be presented by Dr. Nizar Damati and Ms. Maha Asaf. Dr. Nizar Damati is an optometrist and contact lens practitioner. He is an educator and specialist in keratoconus management with contact lens. He has extensive background in training programs in contact lens design, materials, and fitting. He is a member of the International Association of Contact Lens Educators, or IACL, a certified international professional trainer, a certified assessor of the European Foundation for Quality Management, and a member of the Scientific Committee of Jordanian Optometry Syndicate. Ms. Maha Asaf has completed her Bachelor of Science in Optometry from the Jordan University of Science and Technology. She is a contact lens specialist, speaker, practitioner, and specialist in keratoconus management with contact lens. Keratoconus, often referred to as KC, is a slowly progressive, non-inflammatory eye disease that causes the cornea to thin and assumes an irregular conical shape appearance. Today, Dr. Damati and Ms. Asaf will discuss the new generation of large RGP design lenses, as well as fitting techniques for corneal scleral lenses and the indication and patient candidate of corneal scleral lenses. Without further ado, let us give a warm welcome to Dr. Nizar Damati and Ms. Maha Asaf.
Hello, good day everybody. Greetings from Amman, and many thanks to Eyezone education platform, and I would like also to give my special thanks also to Spectrum International for Contact Lens, who provided for us their special slides to educate and train people, our colleagues in contact lens related generation and materials. Okay, it's a pleasure to meet you and to be with you today to have this talk about the KC management with the scleral contact lens and the latest design of scleral contact lens. Before we do start, so I would like to refresh our experience and knowledge in the keratoconus spaces. Actually, I would like to appreciate SmartLens Spectrum International for providing us these slides, valuable slides that we can talk more about. We have our own slides and sharing with SmartLens slides from Spectrum International. Okay, we'll go for the next slide. This is our name and profession. I'm Nizar Damati, an optometrist, as the Eyezone mentioned for us, and my colleague Maha Asaf, also working with me in contact lens clinical practice. And we have, we would like to share with you the latest and updated knowledge about contact lens assistance for KC management, scleral contact. Okay, from the next slide, of course, I would like to share with you this slide how we can see the keratoconus advanced cornea in your right side. And here on the left side, we have the regular cornea. So on the right side, you can see the irregularity, and the patient can suffer from impairing visual acuity and poor vision, especially at night. And of course, the glasses won't be able to correct visual acuity as a crystal vision needs for patients' needs at driving distance, and even some patients with them we can see and observe their cases that they have a counting fingers acuity only. And before you remember, we start to use the contact lens, the corneal contact lens for these cases to improve their vision. But they suffered from discomfort, so they drop out the lenses because of the discomfort. Now, I would like to share with you full questions about uh, contact lenses, what do you use, and what we have to use lately to share together the updates in practice. Let us share with you here what is your favorite lens for case management. Of course, it will be valuable answer from you. Actually, we cannot see it named, but we can see your shares. And in second, we will finish from the book question and we'll go back for our slides to make sure what we. All right. Now we'll go for the next slide to understand most people who mentioned the rigid diameter, what we are majority using. That's true. That's what we were used before. Now, in the right side, you can see the small lens. We were using these lenses to correct vision for early, moderate, and sometimes it couldn't be fit for cases, in some cases, because these lenses can be dislocated. Always the small lens providing discomfort at the same time it could provide a better visual acuity. That's true, and it's correct because we have a new regular curve at the anterior part of the eye, so it corrects the vision. But due to the friction, eyelids friction, and high foreign body awareness, these ones could be annoying for the patients. So the patients can leave them away and behind, not using these lenses even they have valuable better visual acuity. But lately now, the large diameter contact lenses provide perfect combination of comfort and vision. This is what the pure patient is looking for, and many patients, when you start to refer to them, these lenses, large lenses diameter, that it lands on the sclera, vaulting the cornea, no touches and no foreign body awareness, and it goes beyond the limbo. So the patient feels a big difference, and then they express how much they really having better comfort, and they can use the lenses all day long to have better vision and no foreign body awareness at all, and no dislocations, no lens dropout. Go for the next slide and see the design of scleral lenses. Now, we have many designs of scleral lenses to understand how these scleral lenses are developed. Now, they start to have large diameter contact lenses with diameter, bulking the cornea, decreasing the pressure lens on the cornea, peeling these edge lenses on the sclera, leaving the behind the idea of foreign body awareness. Okay, so they started with a corneal. We started, even me, I started my clinical practice with a corneal scleral lenses with a diameter of 14.5, and I found it that these lenses were amazed when I changed the corneal lenses to corneal scleral lenses regarding the feedback of my patients. But when I go for bigger diameter for 15.5, for 16.5, starting from 15.5 and more, I find my patients having less mechanical complications in terms of foreign body awareness, in terms of a dry eye, in terms of comfort, and they feel much, much better with bigger diameter starting from 15.5, 15 to 15.5 and to 16.5. Better comfort and lens stability for using these lenses in term all day long. Uh, Here within the table we can see the classifications and of the scleral lens categories in terms of the diameter. And the most important of these lenses we are measuring it is the sag depth between the lens and the cornea. It should be measured by microns, and we will talk about this in the coming slide. Okay, let's go for the next slide. Why do we fit the scleral lens? We summarize that because it involved the irregular corneas regularly, it involved it regularly, because we need an regular anterior part of the eye supporting the edges 2 to 4 millimeters, okay, beyond the limbal, absolutely to provide better visual acuity than in other lenses, and to prevent any lens dislocation like the corneal lens when it could be dislocated with the eye rubbing from the patients, or hard blinking with the contact lens. So all these things, the patients will be satisfied to use these lenses. Of course, these lenses develop alongside with the design, develop also the material coming now from Contamac and Boston XO2 and with high W also. All right, let's also continue the next slide to also why, because it is very successful because scleral bears the pressure of the lens, as we mentioned a while ago, relieving the cornea, which is the most sensation part in the eye. You know, the corneal lens, it could do some friction and the apical touch sometimes with the cornea, leaving staining, 3-9 o'clock sometimes. That should be now from history. Scleral also far less sensitive, this sensation part in the eye, and that will increase the comfort to be used all day long. Real contact lens also, I call it, is a reward optometry clinic practice for the patients and the practitioners, to providing the best solution for case management as long as there is no corneal opacities, and you can improve vision for tough cases with these lenses. As I really experienced many cases, they were surprised from the results. Even you work alongside with ophthalmologists, other ophthalmic assistants, so they really, you can impress your patients and the medical allied eye health care from the results of using these lenses to the patients. So we have to educate, train people and colleagues, and we have to lecture also the eye care professionals about the benefit of these lenses for the coming future. And you should start with using these lenses to understand the future benefits these lenses to your patients, and use them really with the comfort and the vision. Okay, we go to the next slide now. You can see the vault, how these lenses will vault the cornea. This is a demonstration about how we can observe in a diffuse light the fluorescent pattern on the cornea and the lens. There should be a fluid amount between the lens and the cornea. But in the diffuse light, we have to use the diffuse light to understand there is no corneal touch with the lens and no limbal peering. Now, the corneal irrigated doesn't matter, even if you have ectasia or advanced shape of cornea. Now, it doesn't matter with these lenses. We go for the next slide. Now, the SmartLens Diameters, it comes with a 15 millimeters, the 15.5 millimeters, and the 16.5 millimeters. It depends about the horizontal visual iris diameter and the shape of the cornea. You might need 15 is enough, 15.5 or 16.5. We'll go for the next slide. Also, how we can choose each. It depends also for the shape of the eye and the cornea, and the visual iris diameter with diameter. Okay, let's go with the next slide to see now. Before we do go to this slide, let's go back to the previous slide. Okay, Army, can we go back to the previous slide? Yeah, here with the as large lens we go, the more large lens we go, we need the eye shape needs, like symmetrical different than symmetrical. When we go for the larger size, we need the shape needs. We will share now the second full question, how we can determine the diameter size of the lenses. Let us share the fourth question. Now, can we share scleral lens diameter can be determined by the following? All right, let's go for the next slide. Absolutely, the most important now to see to understand the visual iris diameter and limpal to limpal, and regarding to that, we have to decide, take the decision for the lens diameter, for the eye to take the sag depth. If you have visual iris diameter like 10.50 cornea size, so we will increase it for 3.5 to 4 millimeters, okay, from this diameter. If you have 10.5, so we can go for 15 or 15.5 this diameter, and depending on the corneal shape also it should be in consideration. And if you have visual iris diameter 13.0, okay, so we can increase in consideration 4 millimeter more or 2 points. So we will go for 15.5 or 16.5 lens diameter. In consideration also with the sag depth of the lens, it shouldn't also touch or pierce the limpal part, because the limpal part is the most very important part of the cornea and the contact lens. Because it contains the stem cells, it's very important for the corneal ocular health. So these lens diameter, it should be taken consideration in measurement with the horizontal visual iris diameter. Okay. Now here, as mentioned, the diameter, we can understand the lens diameter size. Let's go for the next slide. As you see now, SmartLens with the smaller diameter for lower, it could be for lower sag depth. That means with the early keratoconus, it could meet their needs. When you have an early keratoconus and a small size of visual iris diameter cornea, so you can start with the lower sag depth. And the larger diameter, it could be for higher sag and higher symmetrically eye shape. So the lower, as you see here from the topography measurements, pictures, and early keratoconus, we can start with a 15.5. And you have to look through the slit lamp observations and find out from limpal, left to limpal, no peering, no impingement, no corneal touch, to avoid mechanical complications. Right here, you have an advanced cone-shaped cornea. You can start, and regarding to my also clinical practice, fact, 16.5 can meet your needs in fitting and be away from the limpal touch or corneal touch. We can adjust the lens with its parameter needs. Now we will understand how the design of these lenses, how it develops to meet your fitting needs and patient comfort. Let's go for the next slide. Now, should scleral lens be symmetric or toric? Okay, that it could be scleral lens need both symmetric and asymmetric to have a toric design. Let's go for the next slide. Now you can see the cornea usually horizontally flatter than vertical, and these lenses comes with, as you see, the shape here, vertically steeper with 150 microns to meet 0 microns at beyond the limpal part. So because of that, These lenses have a special manufacturing and design to meet cases. Let's go for the next slide. As you see here, we have 150 micron toricity vertically and the orientation mark beyond the dimple within 3.5 millimeter almost. Okay, to read the eye shape and corneal shape. Next slide. Now you can see for the next slide the SmartLens Toricity. With the 15, as we mentioned a while ago, with the 15 millimeters lens diameter size, it is a symmetric design. Now, when we start to use, and I actually use most of my cases with the 15.5 to have a front toric and edge toric design to meet the eye shape, most eye shape. So in 15.5, we have 125 micron toricity, and we have more 150 micron toricity in the shape of the 16.5. As you see here, the lens landing beyond the dimple within 3.5 or 4.2, being away from the dimple or corneal touch. This is the most important. You can see that diffuse light observation, there should be no touch. Now, with the narrow lights of the observation, you can measure the fluorescent amount, the fluid amount between the lens and the cornea and the limbal part of the cornea. Next slide. Here, SmartLens, the advanced technology of the toricity side. Now, here the 15, you can see the symmetric design, and here on the 15.5, you can find the asymmetric design, the toric design, as you see horizontally and vertically, and also the same asymmetrically with the 16, to the bigger size of the lens, the more toricity to meet your patient's needs. You should have your own trial set to start setting your patients and to understand the lens design needs. You decide to go for 15.5 or 16.5 and to do your over refraction to understand the spherical and spherical. We will talk about it now for slides. Okay, let's go for the next slide. Always there is advantage of dual depth scleral lenses. This is that can improve your fit and patient's comfort wearing. Of course, these lenses with asymmetric design, it gives you the suction behind. You know, during my practices, I was using symmetric design with all lenses, and sometimes patients finding they have suction. You cannot remove the lens easily as you have a toric design. It's very easy to use these lenses and to have better comfort and vision material. Okay, let's go for the next slide. Now, as what happens when we have the perfect fit, but we have a residual astigmatism. So when you do over refraction, like you have a plano -2, +3, you can do the over refraction and you have to calculate it well and put it in a table as you calculate it with the cylindrical correction and send it to the manufacturer. With the consultant people, they can apply you the same over refraction needed to improve your patient visual acuity needs. Okay, let's go for the next slide. Now, if the back surface is already toric, so then it is easy to make it front toric. As you see here, when you do your over refraction and you decide to have a toric lens, it is very easy. Just make your calculation over refraction and put it in the table and make in consideration the mark orientation. These lenses come to the mark orientation. And you have to decide if these lenses have a rotation or a stable rotation. And this part, you have to mention this is stable, and you have to mention the location of the orientation mark to take in consideration with the manufacturer people how to allocate the. It's very important to decide where is the orientation mark is located. Okay, for the next slide, here is, as you see, the over refraction as we mentioned ago. Now you can see the mark orientation comes horizontally, and after 30 minutes or 40, I believe I used to have some patients, they have a change in sag depth and in power refraction within more than 30 minutes. You have to go to provide enough chair time for your patient to decide the right lens for the right patient to exceed his expectations and find his needs in vision and in comfort. Some patients, when they have more less than 30 minutes, you cannot have the accurate measurement in fitting technically as the sag depth and the refraction power of his need. So he should take enough time because some eyelids quite dense material could do in pigments, and further observation can be changed after 30 minutes or 45 minutes. Okay, so I really advise you to give your patients enough time to have the full observation to prescribe the right lens for him to have better life and comfort and be away from any mechanical complication share time. Okay, let's go for the next slide. Now, I would like to talk about the design, why they call it smart. Because the irregularity, we can design the lens upon every corneal shape needs. Now, in these lenses, you have the central ball. When I put these lenses, when you use these lenses, you have to take in consideration your slit lamp observation carefully. As we see, we start with the diffuse light, and we can see if there is any lens touched or not touched, or excessive clearing or excessive pulling. So, in consideration, in the prescribing these lenses, you have a great table that you can describe your observation. If you, in the central part, if you need to adjust and manipulate, change the central zone in terms of high side, low side, you can change it separately from other parts, like the peripheral curve zone and the limbal, the lifting zone, and the scleral landing zone. If you find you have enough track depth, like 200 micron in the central zone, and you have excessive pulling in the peripheral corneal zone, so you can decrease the curve zone, and you can be stable with the central zone, and you can keep the same amount of the central zone, and you can change only the curve zone. Also, the same thing on the limbal part of the zone. If you find there is no clearance, so you can improve the clearance in the limbal zone, and you can increase the sag within steps, and every steps means 25 microns. Sometimes I ask to improve and increase for steps like 100 microns or less, or if I can find it excessive clearance, I can decrease the limbal zone part. This is the amazing thing with these lenses. And the scleral landing zone, if you can find the flaunty edges, you can ask for seeping, or if you can find any impingement spot in the scleral part cutting blood vessels, so you can ask for lifting within steps, like -1 or +1 for seeping. Okay, this is the amazing parts of this lens design. Actually, this is the best design I ever used in my clinical practice. All my patients really satisfied, happy. I can't really describe much how much they are really happy with these lenses. Very easy to use these lenses, very easy to describe it, very easy to use the table, to fill your technical observations. And also there is a consultations uh, team with these lenses that can help you with the challenge cases like PKP, big cornea, and many other things. Let's go for the next slide. Now, to describe more here and to find more about the fitting, you can see the central zone vaulting zone, orange part, and here also the peripheral corneal zone, the amount. Okay, it could be differ from the central like amount. So as I mentioned, you can choose every part in these lenses to change and to improve for your patient's clinic needs. And you can adjust every part from this lens separately from the other parts. Okay, let's go for the next slide. Now, the initial diagnostic fit, actually, you can start with the 200 microns increments, and you can increase or decrease one step, and each step is at 25 microns calculated. So when you ask to increase or decrease 4 steps, that means 100 micron. When you decrease, you can also decrease the same amount. Okay, let's go for the next slide. Always think microns in these cases. Do we need equipment? What kind of equipment actually do you use as a contact lens specialist? Of course, you have a K reading that can give you estimating when to start, how to start, and the horizontal visual iris diameter, and corneal topography will provide you the corneal thickness with the K readings. And the OCT, you can use the OCT to understand the lens landing. But the most important for me, you should, an optometrist and contact lens fitting user, you should have your slit lamp to understand the fluid amount between the lens and the corneal and the four parts, how it's located on the cornea for your patient's need and your observation. Also, the keratometry can help you how to start again. But the most important, you should have your own trial set. You can start with estimating your K readings, but when you have your own trial set, you can start with the lenses, increasing, decreasing set depth, and changing lens. Then and then stable. Sorry. Okay, let's go for the next slide. Here, this are images coming from my own clinical practice. This is a diffuse light coming from the slit lamp. As the first picture, you can observe centrally excessive clearance. Now, and from the diffuse light, and the second picture is coming also with the ideal clearance. And here you can, the third below image, you can find insufficient clearance as there is an attach. The first image actually, because of the light reflect, now we will be seeing more pictures. Actually, you cannot count only in the diffuse light. Of course, you have to go to use the white light and the narrow light, split light lamp to understand the fluid amount in the four parts of the lens observation of the cornea of the lens design. Okay, let's go for the next slide. Here are many pictures. I took it through my slit lamp observation. If you can see the first one on the left part, you can see there is an apical superior touch on the fluorescein. In the second picture, next to it, you can have better observation with no touch. Here we can go, as you can see here, the first lens is flat, quite flat, so it made a touch. This touch could be after 30 minutes or 45 minutes while patient wearing it or waiting. And here the second part, the second lens, we improve the sag depth of the lens so we can observe there is no touch and we have enough fluid amount, about 200 microns. I believe 150 to 200 microns is enough to have enough oxygen flux into the cornea, having better comfort and no mechanical complications. You can see the center of the third also. I started from my left part. Okay, here the third picture, you can see I'm fully satisfied with this picture as a fluid amount between the lens and the cornea. Okay, this is about 200 microns. Okay, so that will be enough for the fitting process and technically. And you can see the excessive sag depth in the four pictures. So all these pictures can give you enough clearance to decide which lens you have to make. Okay, now you can see the central, and then we go to the mid-peripheral and to the lingual and decide what to take on. So you should have your own slit lamp and your own trial set to start fitting your patients and to meet his satisfaction, to be loyal to you, and you can provide the best assessment for visual acuity care with these lessons for case management. Okay, let's go for the next slide. Okay, now this picture we can understand from my left side the ideal fitting fluorescent amount between the lens and the cornea, which approximately 200 up to 250. That is enough. The central here is, you can see superior any fluid saline, but you can see the centrally appearing touch, and this is not allowed to have it on cornea. And you can see the excessive pooling with high amount of fluorescein or fluid amount between the lens and the cornea, and that can induce hypoxia, and and the patient will be in trouble with the lens with the mechanical complications. Because of that, you can start fitting your patients with a higher sag with the 300 microns, and you can 3 to 350 microns, and leave your patients to wait for 30 to 45 minutes to get him back to your slit lamp observation and to understand his lens sag needs. So you can find lately the lens back down or settled down more about 100 microns, so you can take your decision on the right lens sag depth for him. Now here, how do you choose the initial SmartLens diagnostic? You can, as we mentioned a while ago with the early keratoconus cases, you can, especially with the post-refractive surgery, you can use the low sag, and also with the early keratoconus, you can use low sag and medium sag sometimes to have a good fitting for your patients. Also the BMD, you can use medium and high sag as well. The moderate keratoconus and high sag, you can use an advanced keratoconus with the BKB, wide over BKB, because we have to use high sag and larger lens diameter because they have bigger corneal shape post BKB patients. Okay, let's go for the next slide. Okay, flat meridian remarks. Actually, you have to observe your mark orientations and to understand the meridian markers. And then you have to take in consideration the mark orientation location. Oh, Okay, as the flat meridians markers. Next slide. Now, the larger lens, of course, need the asymmetric eye shape. So these lenses actually will coming with asymmetric design that can meet the eye shape and corneal shape that patients needs. Okay, now we have to go for the next slide. Actually, the simple fit by SAG, as mentioned here, you can start with the 3,800, 4,400. Also, it depends upon your patient corneal shape need. Actually, yeah, these lenses can meet your patient's needs in terms of high refraction power. What I found within the design of these lenses, we have a compromise between the optic and the toric design. So it minimizes the high myopia power refraction. That will increase and decrease the possibility of hypoxia. Some lenses with this design, with especially PKP cases, when I fit them with larger diameter lenses, I can find post high myopia refractive power. With these lenses, I find less, more refractive power error. Now, please, next slide. Now, you can use your flatter base cap and the thinner lenses, as you can use here the 15, as we mentioned ago, here the parameters from the 15 symmetric design and the 15.5 with the toric landing to understand, to find your patient's needs corneal shape. Also, the 16.5 with the toric landing as asymmetric design. Okay, that will be that can cover most your cases, Keratoconus cases needs. Also, if you need an assistant, there is a consultant team that can assist you immediately and directly for your patient needs. Okay, the next slide, please. So here, toric landing creates better outcomes. Of course, the toric landing creates better outcomes in terms of fitting, lens stability, easy to remove, no suctions anymore, and no mechanical components. Okay, next slide. Also, the 16 lens in the urethral set can cover you everything you need for your clinical practice with the scleral lenses, as we mentioned a while ago. You have higher sag depth with the bigger with toric landing design as to meet asymmetric eye shape design. So for the next slide. Now, from the from the simplest to the most complex, you can find your lens design for your patient need, and of course, I'm sure when you start fitting scleral lenses for your Keratoconus case, with these designs, you will find your satisfactions observation as an optometrist and contact lens practitioners to reflect, and that will reflect your patient's uh, happiness and satisfaction to be loyal and loyal to your clinic practice. Also, the ophthalmologist who referred to you these cases, and you have better outcome with these cases for patient satisfaction in terms of comfort and in terms of visual acuity, your ophthalmologist cooperation will continue. During my experience, I really find cooperation with ophthalmologists to give them more knowledge and information about these lenses technically. And when they come back with the results of patients, they really can appreciate your work to help them to improve their patient visual needs. Now I would like my assistant and my colleague will continue with you with the fitting technical approach with these lenses. Okay, please Mahat, go for the next slide.
Stay on this slide, please. The previous slide. Can you go to the previous slide, Agni? No, to the previous one. The previous one, before that. Okay. Hi everyone, my name is Maha and it is my pleasure to continue from here. I will start with a quick revision to what Dr. Nisar said previously. What's special about SmartLens and making life changing actually is because the parameter balance provide. The very diameter and the folder that I mentioned before that we could adjust each during the fitting and the comfortable lens wearing experience. This lenses land in the sclera, which has a fewer nerve endings than the cornea, it makes it less sensitive and more comfortable. There is a polling question I would like to share your opinion with, and then I will continue. Agni, please, the polling question. The polling question, please. The fluid that should be used with insertion should be. Okay, thank you for sharing. Regarding to our knowledge and information, I would like to share with you about the derivative solution called saline. It is very important to insert the lens with the saline because there is a longer contact time with the cornea comparing to other lens modality like the RGB and the corneal lens. That's why we desired the preservative one to maintain corneal healthy and more lucidity. There's also because the preservative one may cause corneal retinal toxicity. Next slide, please. In this photo, you can see many blenders that we use for insertion and removal. The next one. The next slide. Slide, please. Okay. In this photo, you can see one of our patients during her training session. She practiced inserting the lens with the saline by her eye and using it with other plungers, putting it in the inferior side of the lens. It is very important to insert the lens correctly, and thankfully most of our patients we educate very satisfied and happy with this lenses. Next slide. Thankfully most of our patients are satisfied and happy with this lenses because especially the ones who use adaptability before or having previous TCD or severe dryness, they are very happy and satisfied, not complaining about any problem. That's why me and Dr. Desire prepared this lenses for wearing time. Initially, we started it from 4 to 6 hours, then we increasing 2 hours every day, and the maximum wearing hour will be over 10 hours. For the follow-up visiting, we started it after 1 to 2 weeks, and we make a full evaluation about the lens condition, if there's any handling problem, if there's anything related to this thing. Next slide, please. We educate our patients about lens care and explain to them which solution they should and they shouldn't use. It's very important to know there is two types of disinfecting system. There is the multi-purpose one and there is the hydrogen peroxide. The multi-purpose one is using for wetting, soaking, and has in disinfecting for the lenses used, and the peroxide one is used for deep cleaning. Please don't rush the lesson with the patient because many of negative feedback is coming from the correct and correct handling. Thank you. And there is a polling question I would like you to answer after this slide. Lastly, I would like you to tell your patient about strict instruction that you should do not to swim with it, not to swim with it, because it's maybe it's a major problem after that. Thank you. Is there any question?
Okay. Thank you, everybody. Thank you for the Eyezone educational platform, their efforts, their preparation. Thank you. Have a good day.